Hi, everyone. Thanks for joining us this afternoon. Um, we'll be presenting today the top 3 pharmacy abstracts. Your session chairs are going to be myself and Dr. Emily Wong. Neither Emily or I have anything to disclose for this presentation. We'll start off hearing about the effects of acid-suppressing agents in acute pulmonary exacerbations for individuals with cystic fibrosis. Next, we'll hear about the effect of rifabutin on elexacaftor, tezacaftor, ivacaftor pharmacokinetics. And finally, discuss the impact of pharmacy technician managed prior authorization service on provider satisfaction. Our speakers today will introduce prior to each presentation, but to start us off, we'll be hearing from Rebecca Pettit. Dr. Pettit is a pharmacist at pediatric pulmonary ambulatory specialist at Riley Children's Hospital for Children in Indianapolis, Indiana. She completed her PharmD at Creighton University in Omaha, Nebraska, followed by 2 years of residency at the University of Michigan in Ann Arbor, Michigan. And her current research interests include cystic fibrosis, asthma, and transitions of care. Take it away, Dr. Pettit.
Thank you so much for that introduction. And I'm delighted to share with you today our research titled The Effects of Gastric Acid Suppressing Agents in the Incidence of Pulmonary Exacerbations in Pediatric Patients with CF. I have no relationships to disclose with regards to this presentation. So gastroesophageal reflux, or GER or GERD, if you add disease on the end of it, is the effortless retrograde flow of gastric contents into the esophagus. The prevalence in CF patients is really a wide range, anywhere from 35 to 81% of patients. Predisposing factors in CF patients for GERD include airway hyperinflation, frequent cough, the use of different formulas to offset malabsorption in our patients, as well as in some patients, delayed gastric emptying, and the high-fat diet that we recommend for our CF patients to have, as well as chest physiotherapy and some positional changes can increase the incidence of this reflux. To treat GERD, we commonly use drugs from 2 different classes. The first one, the proton pump inhibitors, or PPIs, and you can see the different ones listed on there. And the second is H2RAs, or H2 receptor antagonists, and you can see those listed there. Of note, this research was done prior to the big ranitidine recall, so you will see ranitidine in our results. So if we look at the use of PPIs and H2RAs in our CF patient registry, this is the 2018 data. You can see that PPIs and H2RAs are commonly used in our CF population. If we look at the lower age group, so the less than 1 to 2 years of age, we see that H2RAs are the most common agents. And then after that age period, PPIs become more commonly used in our patients. So if we look at the current literature about acid suppressant agents in CF patients, in adult patients with CF, PPIs have been associated with a significant increase in number of hospitalizations. In pediatric patients, one study found that there was a significant number, higher number of exacerbations in patients that were on PPIs, at least one exacerbation during the 1-year time frame compared to those that were not receiving PPIs. And when we look at the literature in adult patients without CF, we see that PPIs can increase the risk for developing hospital-acquired pneumonia and other infections as well. So the objective of our study was to determine the incidence of acute pulmonary exacerbation with 1 year of starting a PPI or H2RA in our pediatric CF patients. We define an acute pulmonary exacerbation as an inpatient CF admission, clinic visit, or sick call that the patient was diagnosed with an exacerbation and required the initiation of new oral or parenteral antibiotics. This was a retrospective observational single center study, and we looked at patients that were started on acid suppressing agents between July 1st, 2016 and June 30th, 2018. Patients were age matched in a 1-to-2 ratio with control patients. We included patients that were diagnosed with cystic fibrosis that were followed at our clinic, and we excluded those that were over the age of 18 and if their duration of gastric acid suppression was less than 1 year. So you can see here that we had 25 patients in our acid suppression group that were age control matched to our 50 in the no acid suppression group. As you might expect, since we age match patients, there is no difference in the age of the patients and no difference in gender as well. We also looked at patients on pancreatic enzyme replacement therapy, and there was no difference in those patients either between the two groups. As you might expect, patients in the acid suppression group did have a higher incidence of the diagnosis of gastroesophageal reflux, and there was no difference between the two groups in genetic mutations or CFTR modulator use. When we look at what acid suppression agents were used, the majority of our patients were on ranitidine, just over 50%. And the other patients were on PPIs there. There's 4 different ones. The most common PPI being omeprazole, which really correlates to what is commonly approved by insurance in our region. If we look at the doses, the mean dose of ranitidine that was used in the study was around 7 mg per kg per day, so a moderate dose there. And then of our PPIs, right around 1 milligram per kilo per day. When we look at the impact on exacerbations between those on acid suppressions and those not on acid suppression, we did not find any difference in those requiring hospitalization or requiring outpatient antibiotics. And these outpatient antibiotics could be oral or IV antibiotics. I'd say most commonly these were oral antibiotics. And the total number of exacerbations was similar between the two groups. When we look at change in BMI as well as FEV1, we did not see a difference between those on acid suppression and those not on acid suppression. Of note, not all patients in our population had FEV1s due to their age. When we look further at our patients on H2RAs versus their matched controls, we found no difference again in hospitalizations or outpatient antibiotics or total number of exacerbations, and did not see a significant change in BMI between the two groups. When we look at H2RAs versus our patients on PPIs, we did find that patients on H2RAs were younger and than those that were on PPIs, which is likely, kind of mirrors what we see in our CF Foundation registry data as well. We did not see any difference in hospitalization or in outpatient antibiotics or total exacerbations either. And then similar to the other groups, did not see any change in BMI between these two patient groups. So in our study, we found that more patients in the acid suppression group had the diagnosis of gastroesophageal reflux disease, which you might expect. And we found no difference in incidence of acute pulmonary exacerbation between those on acid suppression, those that were not. No change in difference in BMI or FEV1. When we looked at H2RAs, these were in our younger patients versus the PPIs in our older patients. However, when these two groups were compared to their age-matched control, there was no difference in exacerbations between the two groups. So in conclusion, the treatment of gastric acid suppression agents in CF patients in this pediatric cohort did not appear to increase the incidence of pulmonary exacerbations. However, further studies, especially of the long-term impact of these agents, would be great to have, as we know many of these patients are on these agents for longer than a year. So the long-term impact would be interesting to explore in the future. I want to thank Kenneth Shepard, who was a resident with us last year, who did a lot of work on this project. And thank you to the organizers for allowing me to present. And with that, I will take any questions.
Fantastic. Thank you so much, Dr. Pettit. We do have our first question ready. I'd like to remind everyone that you can ask a question in the Q&A box. Please use that rather than the chat box so we can quickly sort through your questions. And Dr. Pettit, we will dive into your first question. So question 1, were the patients matched for lung function in this study, or did you find that sicker patients in general were placed on acid suppression?
So we did not match based on lung function. We only matched based on age, although hopefully age may help with some of the lung function disparity, but may not. We did not find that sicker patients in general were placed on acid suppression, at least from what we could tell from the data we looked at.
Excellent. All right, our next question. Did you look at the dosing difference in PERT between the two groups, or in pancreatic enzyme replacement therapy between the two groups?
Yeah, that's a great question. We didn't look at the difference in dosing, but would be something interesting to explore. We just looked at if patients were on enzymes versus not on enzymes. So that would be interesting to look at to see if we have any differences there, which we may, given what we know about the effects of acid suppression agents on the efficacy of pancreatic enzymes.
Fantastic. And I think we have time for one more question for you. Our third question is, did you look at any subgroups, such as genotype or certain genotypes associated with pancreatic insufficiency?
We did not look at any subgroups. We did look at our overall acid suppression versus non-acid suppression groups and looked at homozygous delta F5 weight, heterozygous delta F5 weight, and other, and didn't see any difference between the two groups there, but didn't delve into anything genotype specific. I'm not sure, given we only had 25 patients in our acid suppression group, if we'd have enough to kind of look further into that.
Thank you so much. Everyone, feel free to continue to drop questions in, because we can circle back to those later if we have some time at the end. But we will move on to our next speaker. So I'd like to next introduce Dr. Yujin Hong. Dr. Hong is currently a PhD student in the Dr. Beringer Lab at the University of Southern California School of Pharmacy. Prior to that, Dr. Hong received her PharmD at the School of Pharmacy and Seoul National University of South Korea. And take it away, Dr. Hong.
Okay, thank you so much for nice introduction. The title of my presentation is going to be the evaluation of the drug-drug interaction potential of rifabutin and trikafta using a physiologically based pharmacokinetic simulation approach. And there are no relationships to disclose related to this presentation. Okay, so I want to first briefly introduce about non-tuberculous mycobacteria in CF population. NTMs are increasingly being isolated from CF And the most commonly identified species in CF is Mycobacterium avium complex, which is called MAC. This NTM can cause progressive inflammatory lung damage, a condition termed NTM pulmonary disease. So there is a retrospective study regarding this, a study of CF subjects with at least one positive NTM culture. Here, subjects were assigned to 3 different groups. Active group consisted of subjects who showed clinical and radiographic progression of disease based on ATS criteria. And here we could see that the subjects with active NTM disease showed accelerated rate of decline in FEV1 when compared with other groups, suggesting that they will need effective treatment against NTM disease. And there is a treatment guideline of NTM in CF, and especially the guideline for MAC recommends 3-drug combination regimen, which consists of azithromycin, rifabutin, and ethambutol. This combination regimen is known to prevent the emergence of macrolide resistance, which is associated with poor clinical outcomes. However, among those, rifabutin is currently contraindicated with Trikafta, which is a triple combination therapy consists of elexacaftor, tezacaftor, and ivacaftor. So these can be therapeutic challenge to the treatment of NTM disease in people with CF. So in the next slide, I'm going to talk more about these contraindication issues of Trikafta. So here's the metabolic pathway of ETI components. All 3 components are metabolized by CYP3A enzyme, generating potent active metabolites, so these can create potential for significant drug-drug interactions. Indeed, previous clinical data show that co-administration of rifabutin decreased the AUC of ivacaftor by almost 90%. So that's why it is currently contraindicated with strong inducer. So in the Trikafta package insert, there is a statement regarding this: do not take Trikafta with rifabutin or rifabutin, which are the known CYP3A inducers. However, while rifabutin also induces CYP3A activity, its effects appear to be more moderate when compared with rifabutin. So we brought up this publication that compared rifabutin and rifabutin, their effects on rosavirin, which is also the CYP3A4 substrate. And we could see here that the level of decrease in rosavirin AUC was less in case of rifabutin than rifabutin. So we thought that rifabutin may offer alternative to rifabutin in patients receiving ETI triple combination therapy. That being said, we hypothesized that rifabutin can be co-administered with ETI components in patients being treated for NTM-PD. And we have 2 aims here. One is to determine the effect of rifabutin on the PK of ETI. And the other one is to determine the appropriate dose of 3 components to overcome the induction effect mediated by rifabutin. So for the aims of this study, we predicted drug-drug interaction utilizing PBPK simulation approach implemented with Simcyp software. This PBPK model is increasingly being included in regulatory submissions in support of guidance on drug interaction management of new drugs. So with this flow chart, I want to first briefly introduce the steps that we took before going into the detailed data of each step. First, for the model development of Trikafta, we utilized system components and drug-dependent components from clinical data or in vitro data. And for the model, we simulated 100 subjects who are older than 18 years old. Then we verified this model using PK simulation data. Here we determined whether the simulated PK parameters match with the observed PK parameters of these components. And the next step is again model verification, but this time using drug-drug interaction data. Here we determined whether predicted drug interaction match with the clinically observed interaction data with rifabutin or itraconazole. Then finally, we applied this model to simulate the drug interaction of these 3 components with rifabutin. So this is the data table of ivacaftor, which is the most sensitive CYP3A substrate among 3 components. And we collected its physical-chemical properties as well as its absorption, distribution, clearance parameters which could be obtained from various sources, including regulatory documents or publications. And similarly, we also obtained data for elexacaftor and tezacaftor, mostly from NDA documents to develop their model. So this slide describes how we verified our PBPK model. And when we compared predicted data with observed PK data, all the comparisons were within the range of acceptable model performances. For example, ivacaftor predicted AUC was 10.9, which was around 90% of observed AUC. We also compared simulated drug interaction data with the observed drug interaction, and we verified that all the data could closely predict the observed Cmax or AUC ratio. For ivacaftor and rifabutin drug interaction study, the predicted AUC ratio was 0.12, which was close to what previously observed. So since we verified our PBPK model, now using this model, we tried to predict drug interaction with rifabutin. We simulated this conventional dosing regimen of ETI with rifabutin 300 milligrams to see their interaction. And this is the result of simulation. So for ivacaftor, we got 0.34 of AUC ratio, and tezacaftor, elexacaftor AUC ratio was a little bit higher than that. And from this simulation result, we could conclude that rifabutin can be used together with this modulator because lumacaftor, which is also CTJ inducer, decreased ivacaftor exposure by 80%, but still it is clinically used with ivacaftor as a combination therapy. So we concluded that predictive data above supports our study hypothesis that rifabutin can be used with ETI components. Then we tried to determine potential dose alterations of ETI components to overcome the drug interaction that we simulated before. And based on several simulations, the dose of ETI should be increased to this regimen, which could provide similar steady-state PK from around 80% to 100% of conventional regimen of Trikafta alone. And the graph below shows the plasma concentration profile of ETI components with or without rifabutin. And this blue line shows the increased dosing regimen started on day 3. And we could visually see that the increased dosing regimen with rifabutin could closely mimic the PK profile of conventional dosing regimen without rifabutin. But still, there is some limitation of this study. As I mentioned earlier, there are active metabolites of ETI, and the active metabolite of elexacaftor and ivacaftor were not incorporated into this PBPK analysis due to the insufficient information to build a model. We could only include active metabolite of tezacaftor, but this is the most important active metabolite because M1 tezacaftor's potency is similar to tezacaftor, but its exposure is even higher than that. And we confirmed here that with an increased dose of tezacaftor, both tezacaftor and M1 tezacaftor could achieve a similar level of exposure to the tezacaftor alone, so there was no risk of metabolite accumulation. But the other two metabolites are either less abundant or less potent, so they might contribute less significantly to the overall efficacy. To conclude, since this simulation we employed could robustly predict PK parameters and several drug interactions of ETI, it can be also used to evaluate and provide guidance on other potential drug interactions involving these components. And our simulation result with rifabutin will allow the use of primary treatment regimen that includes rifabutin in the treatment of MAC disease in CF patients receiving ETI components. But a further clinical trial might be needed to confirm our dosing recommendations. And I would like to thank Dr. Berenger, who is my principal investigator and guided this whole research. And I would like to thank you all for listening.
Thank you so much. Again, We'll be taking questions from the audience with the Q&A function, not the chat function. So please do include those in the Q&A if you have some. And the first question that we have, until there's further research in this area, would you recommend patient-specific therapeutic drug monitoring for patients that are receiving an adjusted regimen due to drug-drug interactions?
Okay. Yeah. Still, I think even though we through the PBPK simulation, we confirmed that our dosage recommendation could achieve the similar level of steady-state PK profile of Trikafta, but still there was no clinical study of it. I guess still it is better to conduct TDM to make sure that patients are achieving the target level of the PK profile. So.
Okay, great. The next question we have for you is, would you expect liver toxicity to be higher with the higher dose of Trikafta and rifabutin?
I see. So since with rifabutin-trikafta level will be decreased without adjusted dosing regimen, I guess since the PK profile of Trikafta is gonna be similar, even though we increase the dosage of it, I guess liver toxicity will be doesn't change. The incidence of liver toxicity will not change if patients can achieve the similar level of Trikafta PK profile.
Yeah, very, very difficult questions today.
Yeah.
One more, and then I know for time we probably do need to move on. The last question we had for you for today will be, which other CYP3A4 substrates would be the best candidates for this type of research?
Usually people use midazolam or testosterone for prototypical CYP3A4 substrates because they are the known and very sensitive CYP3A4 substrates. So I think it's always better to simulate them as a control to make sure that all the simulation works well. So I think those are the main CYP3A4 substrates that people usually try first to verify their model.
Fantastic, really interesting. Thank you so much. And for our final presenter, we'll be hearing from Dr. Erin McDade. Dr. McDade is the Assistant Director of Clinical Pharmacy Services and a clinical pharmacy specialist for Baylor College of Medicine Pediatric CF Center at Texas Children's Hospital. Dr. McDade completed her PGY1 pharmacy residency at the University of Arizona and her PGY2 pediatric residency at Texas Children's Hospital. You can go ahead and take it away, Dr. McDade.
All right. Thank you for that introduction. Again, my name is Erin McDade, and I am a clinical pharmacist that works with the Baylor College of Medicine Cystic Fibrosis Center at Texas Children's Hospital. And on behalf of my team, I will be presenting our project looking at the impact of a pharmacy technician managed prior authorization service on nursing and physician satisfaction. I do not have anything to disclose. So as we all know, the prior authorization is an inevitable part of prescribing medications for the cystic fibrosis population. Historically, at Texas Children's Hospital, our prior authorizations have been managed predominantly by our CF Center nursing staff. And to those who aren't aware, pharmacy technicians have a vast array of medication knowledge and experience in managing inventory and payer preferred NDCs, and are well suited to assist with prior authorizations for really any population of patients. And because of this, we decided at Texas Children's to hire a CF pharmacy technician to join our clinic and assist with prior authorization management as well as other medication acquisition tasks. So our CF pharmacy technician is a full-time position, which is partially funded by the CF Foundation grant and the other portion funded by our Texas Children's Hospital specialty pharmacy. Prior to implementation of our pharmacy technician, we planned a phased approach into the variety of roles that we wanted her to take on. And as you can see in the red highlighted boxes in phase 1 and 2, really the first thing that we wanted her to work on was to manage prior authorizations independently. And so throughout this about 4-week time frame, right after she joined our practice, we really focused on prior authorization management. And that was to our benefit, fortunately, because you can see in the dark blue box, the timeline of our technician joining our team. So Jessica, our pharmacy technician, joined us at the end of September in 2019. And approximately 3 weeks later, Trikafta was approved by the FDA, which fortunately, we had about 120 patients eligible for the drug at that time, and all of those patients required a prior authorization. So essentially, immediately at that point in time, Jessica's efforts were focused on managing the Trikafta prior authorizations. And then over the course of her tenure for the last year, her scope has been expanded to other CFTR modulators and many of the other specialty CF medications. So the objective of our study was to evaluate the impact of our CF technician managed prior authorization service on our CF center by approximating the amount of time that we were able to give back to our nursing staff, as well as determining the overall nurse and physician satisfaction and their perceived impact of this new pharmacy technician role on patient care. So this was a retrospective chart review of our pharmacy technician's notes describing her efforts at managing prior authorizations from December 1st, 2019 through February 29th, 2020. One thing that was excluded were any prior authorizations that she did not complete entirely. So if a nurse or a pharmacist started the prior authorization, then handed it off to her, those prior authorizations are not included in this analysis. So we collected a variety of data points, including prior authorization turnaround time, the estimated time we gave back to the nursing staff, the type of medications that she performed prior authorizations on, and then the estimated time required to collect the data and compile the information necessary to submit the prior auths. As I mentioned, another one of our objectives was to assess the satisfaction with our pharmacy technician role. So we created 2 surveys, one for physicians and one for nurses, to assess the overall satisfaction with our technician role, the impact our technician has had on patient care, and then how much time the nurses perceived they were dedicating to prior authorization management pre and post technician implementation. And then we asked for a value added rating from both our nurse and physician work groups regarding what value they thought that our technician added to our CF center. We did evaluate a balanced measure of prior authorization turnaround time. As I mentioned, our technician started in September, and we were studying a time frame shortly after that. So we wanted to ensure that her prior authorization turnaround time was comparable to national average. So some definitions before we get into the results. Prior authorization turnaround time was defined in 2 different ways. If it was an initial prior authorization, we calculate that as the time from the medication order in our electronic medical record to the time that we got the notification that the prior authorization was approved. If it was a renewal, the time was counted as soon as our technician was made aware that the authorization was required to the time of approval notification. And then we estimated the time that we gave back to our nursing staff by having our technician give us an estimate of the amount of time it took her to compile and manage the prior authorizations for each drug that she did prior authorizations for during our study period. Took that average time, multiplied it by the number number of prior authorizations for that particular drug, and then summed that up to give us the time that we would estimate that we had given back to the nursing staff. So these are just a quick view of our surveys that we sent to the nursing and physician staff. We'll go through the questions in a little bit more detail as we go through the results section. So our first outcome that we evaluated was the time that we gave back to nursing. And as I described when we went through the definitions, these are all of the drugs that she performed prior authorizations on during our study time period. Her estimated time to complete and collect and assemble all of the prior authorization documentation, the number of prior authorizations completed. If an appeal was needed and completed, we tabulated that as well and gave that an additional hour's worth of work time, and then summed it all up to an estimated 85.5 hours that we gave back to the nursing staff during this 3-month period. I will note that this is probably an underestimation. As I mentioned in the beginning, we excluded any prior authorizations that were co-managed by our technician and nursing or pharmacy staff. So if we were to include those, I believe this number would be much higher. So just to summarize the prior authorizations that were completed by our technician, the majority of them were CFTR modulators. As I described in the beginning, that was her main focus during the beginning of her tenure with us. And then as far as her approval, the approvals of these prior authorizations, 56 out of the 66, so 85% of the authorizations were approved initially. The 9 that were denied, we submitted appeals for all of those, and only one of those appeals was ultimately denied for an overall rating, approval rating of around 98%. So this depicts our balance measure, or the prior authorization turnaround time. So this box and whisker plot shows that the median turnaround time for the prior authorizations managed by our technician during the study time period was a little less than 4 business days. You can see on this graph, the dark blue or light blue line denotes the national average that we obtained from URAC specialty pharmacy data. And you can see that that national average is around 6 business days. So our technician is doing a fantastic job managing our prior authorizations, even despite only having been hired a few months prior to our study. You will notice that there are some outliers, and those happen for a variety of reasons, but most notably, this study period did include the holidays, and we also did prioritize the patients that we initiated Trikafta on based on their severity of illness, so that may have played a role as well. So for our survey results, our nurses responded, and let me back up. So there were 4 nurses that we surveyed. All 4 of those nurses responded. So we had a 100% response rate. Prior to implementation of our technician, they estimated that about 35% of their time was spent managing prior authorizations. And then after that dropped significantly to 9.4%. There was also 100% of the nurses responded that they were very satisfied with the amount of time they spent managing prior authorizations after implementation of our pharmacy technician, compared to 25% before. 100% of the nurses responded that they were very satisfied or strongly agreed that our pharmacy technician improved the nurses' time that was spent on prior authorizations, increased their ability to provide the best patient care possible, that the initiation of our technician led to fewer medication delays and improved the nurses' quality of work life. So that average value added rating by our nurses was on a scale of 1 to 10, 10 being the highest value added by our technician, and the average score was 9.75. Our physician survey results were very similar. We sent our survey to 15 physicians and we got 8 responses for a response rate of 53%. 100% of the physicians responded that they strongly agree that our technicians streamline our PA process, improved patient care, improved communication about medication status, as well as improved time to medication start. Again, 100% of the physicians responded that they were very satisfied with the technician's impact on our patients and our CF center. 88% responded that they strongly agreed our technician resulted in fewer medication delays. And similarly to our nurses that were surveyed, the physicians gave an average value added rating of 9.75 for the addition of our pharmacy technician. So in conclusion, this study endorses the addition of a pharmacy technician as a supportive and very important role in CF centers. The CF pharmacy technician allows nurses and physicians to spend more time in direct patient care roles, which results in better perceived patient outcomes and better overall satisfaction for our nurses and our physician colleagues. I would like to acknowledge first and foremost our pharmacy technician, Jessica Ferdinand, who has done an amazing job jumping into a new role and has really done some absolutely fantastic work over the last year. Also to Gloria Lee, who is a pharmacy resident who helped compile all of this data, and the rest of our CF team who helped with this project. And if anyone would like to see any more in-depth data, please visit our poster, which is number 543. And with that, I'll take any questions.
Fantastic. So question number one that we have for you, what other roles does your pharmacy technician play in the clinic? Do they see patients for med histories, do any copay assistance, enrollment, or other tasks like that?
So we have expanded her role to assisting with enrollment in copay programs and other patient assistance programs. She also helps us with patients who we know have poor adherence and tries to help consolidate pharmacies and really reaches out to those families to see what's going on, to see if she can help. She does a lot of HealthWell enrollment and a lot of kind of copay assistance and management.
Fantastic. Our next question for you, it does sound like some of this was relatively manual documentation. Does your team use a patient management system or portal to track PA or appeal status?
Not that I'm aware of. Most of what we do is manual charting in the electronic medical record.
Okay. We do have one question for all of our speakers today. So I'll cut us off there so we can get to that final question. Before I open that one up, I want to say a really big thank you to, of course, my co-moderator, Emily, for doing so much behind the scenes and keeping me organized today. To all of our speakers for sharing their work with us. This was really fantastic to see in such a wide variety of projects, and just really cool to be involved in for Pharmacy Week, right? What a great way for all of us to celebrate. And I want to thank both Jeff and Dave for all of their insight and for helping Emily and I out as we were preparing for this session. Really appreciate the great communication from both of them. So our final question for all presenters that we received was, based on what you learned from your research and from your retrospective studies, have you discovered a problem or a gap that you would like to solve with prospective improvement work? Whoever is most excited to jump on that one can go first. I won't call on any of you.
All right, I'll go first. So I think there's plenty of questions I've thought of that would be great for prospective, especially from the improvement work. I think related to what I talked about today, acid suppression therapy, I think at least at our center and maybe other centers as well, we could probably use some prospective improvement work on taking patients off acid suppression agents after a period of time. I feel like these are particular medications where they get put on and they just keep being re-prescribed, and no one ever asks why, and does the patient really need it? So I think definitely an area that could be, in a lot of centers, an easy area to work on from a quality improvement perspective from a prospective lens.
Fantastic.
I can take a stab next. So from the implementation of a pharmacy technician standpoint, I think there are, countless roles that a pharmacy technician can play. And we're literally just at the tip of the iceberg with what our pharmacy technician can do for our CF center. And I don't think that that role is highlighted enough. So I think there's a lot of opportunity for quality improvement and research into the impact that a pharmacy technician can have on the pharmacist time, nurse's time, physician time, but also the direct impact to the patients. I think it would be really fantastic to survey our patients and see, what an impact that she's had on their lives, because I know that she's really touched some of our families with all of the work that she's done.
Wonderful. Yeah.
For me, as I just briefly mentioned in conclusion slides, I think prospective clinical study might be needed to confirm our dosing recommendation and also improve our research results, because as a limitation, we couldn't include the active metabolite of elixacaftor and ivacaftor. And also there can be variation in the clinical setting. So in the future, I guess we might need to conduct a clinical study to confirm our dosing recommendations.
Wonderful. Great. Well, it was, again, great to hear from all of our speakers. I'm going to quickly just run down in order the poster numbers for our speakers, so anyone who's interested to see can follow up on those. I know we got some comments that a couple images were a little bit small to see. So if you are looking for these posters, the first presentation was abstract 528. The second one was abstract 529, so right next to each other in the virtual space. And then the final one was abstract 534. So please go check out those posters, go ahead and zoom in if there are things you want to see a little closer up, and I'm sure any of our speakers would be happy to answer questions in the future if you email them as well. Thank you again, everybody, and we will let you get on with your evenings.